So as a physician, it's never been truly comfortable or encouraged to speak about one's own illness, vulnerabilities, physical challenges. We're told early on, even in medical school, that we should just soldier on, move through the challenges, and the implication was always to prioritize the work over our own health. This is a problem since illness does affect the lives of physicians and clinicians like anyone else. During the pandemic, I was so struck that, in a way, the public was certainly privy to this, to the frailties of the medical system and the significant toll on healthcare workers. But even outside a pandemic, the question of how to take care of medical staff as well as patients continues to elude this country. We have so much to learn about particularly how to heal healers. Welcome. This is Gynocurious. I am your host and the creator of the show, Dr. Amy Novatt. From both sides of the speculum, we are here to investigate what it means to be a healer and to be healed. Please let us hear from you by writing to comments@radiofreerhinecliffe.org or gynocurious@gmail.com. Let us know your thoughts. So today I want to welcome Dr. Amy Rothenberg. She is a licensed naturopathic doctor since 1986. She was also the longtime medical editor for the Institute of Natural Medicine. When diagnosed with cancer in 2014, Dr. Rothenberg sought care at a renowned teaching hospital and also worked with providers in integrative natural medicine, oncology, to create her medical dream team, as she calls them. She's here today to talk about what it's like to be a clinician, an expert in the health of others, and her own journey into illness and recovery. Good morning, Amy. Welcome.
Thank you for having me.
It's so nice to see you and be with you today. So let's just start. I'd like to start with kind of talking about professional arcs and how people came to be what they are today. So naturopathy, how did you go from being a teenager somewhere to becoming a naturopath?
Yeah, it's a very interesting story. Like many of us, I grew up wanting to be a doctor. I just thought I was going to be a doctor. It wasn't anything that was pushed by my parents, who were, sort of children of immigrants and not particularly educated. I just felt this was the right kind of job for me. In the course of my childhood, I lost my dad when I was 12. He had a heart attack in his sleep. I lost my mom a couple of years later to breast cancer. And in those days, the treatment, this is in the 1960s and 70s, the treatments for both of those illnesses were not what they are today. I'm sure if they had what they had then now, they would have survived these events and diagnoses. But I became disillusioned with the conventional medical world. And I thought, okay, I'm not going to be a doctor. They certainly didn't help my family. But the truth of it was, once I got to college, I was drawn to every class in the biology section. I loved chemistry. I was really pulled into the sciences area. And I went to Antioch College in Yellow Springs, Ohio, which is known for its work study programs. And one of my very first work programs, I went to Portland, Oregon to work at the University of Oregon Health Sciences Center in a research lab, mostly because I was drawn to the idea of data informing questions and questions informing scientific discovery. It happened that I moved into a group household, mostly because it was conveniently located and very affordable. And the three roommates that I had were three naturopathic medical students. They were second, fourth year students. I had never heard of the word naturopathic. This was 1978. Obviously, there was no internet, and there was Prevention Magazine. Prevention Magazine, I think, ran a little ad about naturopathic medicine in those days, but I had never seen it. I'd never heard of it. And honestly, I thought it had to do with trail maintenance around nature paths or something. I really had no idea. But the very first night, sitting at the dinner table, they started talking about what their education was all about and what they were learning about, and the philosophical tenets of, we're going to be interested in treating the whole person. We're looking at the healing power of nature and the human body's inherent capacity for healing. We are going to be working with the concept of doctor as teacher and working to educate patients around key areas related to diet, exercise, the head game, or we weren't calling it that in those days, the role of stress in health and disease, and the use of natural kinds of medicines from the herbal world, from hydrotherapy, from things that work with this inherent capacity of healing. Anyway, the philosophy drew me in like it was a profound spiritual moment for me. And I realized, oh my God, maybe I can still fulfill this dream of becoming a doctor, but do it in this way that was much more aligned with my own natural state in terms of I was a runner, I did yoga, I was learning how to meditate. And mind you, I was only 18 at the time. So to learn about a profession that was so well attuned to my natural propensities and interests, and also brought in everything related to biology and the living sciences, it was really meant to be. I never wavered after that. It was a straight arrow to complete all my prerequisites, which are the same prerequisites as one needs to go to conventional medical school. And I graduated Antioch in June with a degree in biology, and I started naturopathic medical school in August. Just boom, 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 boom. Met my husband the first day of school. I mean, it was just all of these things kind of lined up.
It was in the stars. Yeah, it's great.
It was in the stars. And so that's my arc. And I've never wavered, but I will say that as the years go by, I sense and feel and observe that the conventional medical world is a very big ship and turns slowly, but is in many ways turning toward preventive medicine and whole person care and understanding the role of stress. And so I think there's a beautiful meeting that's starting to really happen and take root. And I'm very thrilled to be part of that.
Great. Well, I think, my next question was for you to help the audience know what naturopathy is, but you just did so. But is there anything else that you might, words you could use to help differentiate what most people know as doctor's offices from the way the experience in a naturopath's office might be?
Yeah, I think there's quite a lot that's similar. Of course, it depends on what kind of doctor you go to for your, medical care to start with. But I think in a naturopathic family type practice, which is what my husband and I who practice together have had, it looks quite similar. The actual office, the equipment that we have out, the kind of blood tests, analyzing other bodily fluids, whether it's urine or stool or what have you. I think we might go a little broader in terms of some of the diagnostic tools that we have. And then we are looking for not only sort of what the problem is that the person has and getting that accurate diagnosis, but also trying to understand the arc of that patient's story and where they were, how they got here, where they're heading, what's the trajectory of their health if they don't do anything, and then really applying the naturopathic medicine philosophy to the treatment approaches. And every naturopathic doctor is different. Sort of, you're just like in conventional medicine, you're given a group of tools, and then you sort of find your way with which tools work best in your hands. I say for my practice, that has been largely leaning into the therapeutic role of nutrition, the use of botanical medicine, the use of some hands-on approaches relating to balancing the musculoskeletal system and the spine. And then we use homeopathy, which is its own separate kind of natural medicine, alongside nutritional and botanical supplements in pill form, tea form, tincture form, always working with what the patient is ready for, never throwing the whole book and every possible thing that could help. But what is this patient who's come to see me? What are they able to do? What are the sustainable changes they could make that could alter the arc of their own health? While I'm quite interested in helping a person in the moment I'm seeing them, obviously, especially true for people with an acute illness, but many people who come to see me are people who have chronic ailments that they're not getting better from anytime soon. And I'm interested in what is the arc? What is the projected arc of their health if they don't make any changes? And what are the small things that we might be able to do that can help them toward a better outcome and to a better quality of life? It's not just enough to be symptom-free, but we're also interested in having people feel good, have energy, be able to do the things they love with the people that they would like to be with.
Lovely, lovely. Thank you for that description. I want to get more granular to your experience. And as a person who takes care of others, you had an experience with cancer in 2014, I think it was. Can you tell us about that experience and tell the audience what your
You bet.
diagnosis was?
You bet. My husband and I are big ballroom dancers, and it was New Year's Eve going into 2014. We went out dancing. I came home at 4 in the morning.
Wait, we got to stop. What do you wear when you ballroom dance? Do you wear the whole thing or?
I do social ballroom. Social ballroom is not so much about the clothing. However, it was New Year's Eve. I was in a beautiful gown.
Excellent.
Short gown, because it's easier to dance in something a little shorter. And anyway, we had a fabulous night, and I danced every dance. And in social ballroom, the idea is you're going to dance with everybody there, and
Great.
give each person the best dance of the night. I felt really at the top of my game, the top of my world. My third kid had left for college a few years before. My husband and I were refining each other, as many of us do after the kids leave home. And my work life was just coming along, and I had just published my first book, and life was very, very good. And in the morning, I found a lump in my breast. It was not small, and it just sort of appeared. And I had a normal mammogram a few months before, and I had been under a regular, quote unquote, surveillance because I had a very strong family history of breast cancer. I had tested negative for the BRCA mutation twice, once in my 40s and once in my 50s.
So you had already gone through some genetic testing. So you mentioned your mom had breast cancer. Who else had cancer?
And my sister had breast cancer a couple times and ovarian. And she had also tested negative, interestingly enough,
and this was
for the BRCA mutation.
Okay.
But the geneticist that I saw, a wonderful woman who's the head of breast cancer genetics and research at Dana-Farber, she said, Amy, your sister has disease and she was negative. The chance of you being positive is so low, I don't even think we should do the test. I pushed it. And afterward, when I got the negative test, she said, told you so, basically, kindly. But nonetheless, I developed breast cancer. I went to have treatment begun, and they were like, oh, you just need lumpectomy, a little radiation. And I was like, you know what? Take them both. Take them. Because my sister had breast cancer twice and ovarian cancer. We might not have that, but we clearly have something, and I don't want to be going through this again in a few years. And I was done having children in nursing, and I was very clear, just take both breasts. Okay.
How did the medical community respond to that? Were they supportive?
They thought I was going way overboard. They also asked me to get tested again. And I said, I was just tested last year. They said the test continues to get better, which I knew.
Right.
But I mean, how often does one do a test like that? Well, the third time was the charm, not the one charm anybody wants, but it was the information. Our family, unfortunately, carries a deletion of the BRCA mutation, which is something that a deletion is a type of mutation, but it's not something that was being looked for. It's hard to see a deletion. Right. But of course, not anybody who's tested now, and starting in about 2012, 2013, right after I had done my second test, it gets tested also for a deletion. So I turned out to be positive. So then, of course, everybody was relieved I'd had the double mastectomy because I would have had to go back and do that, in the future.
Yeah. How was that surgery? How was that surgery?
What's that?
How was that surgery, having the double mastectomy? Because I'm sure there are listeners out there who are either considering it or went through it. And what was it like?
Double mastectomy without reconstruction, you have to think about the breast. If anybody has ever worked with a chicken breast, the breast comes out somewhat wholesale, the breast tissue, and your skin is left entirely intact. So it's not like somebody's cutting off your breast. It's not that. They're going very carefully in under the skin and removing the breast tissue, which goes a little bit, into a tail, into the axillary armpit area. I think if you're not having reconstruction at the same time, a double mastectomy is not a picnic. It's a surgery, but it's very external to any of your, dear inner organs. Most people do quite well with it. I had done a sort of deep dive on research about reconstruction and the use of implants, and read and appreciated that for many women, and it's so individual, but for the kind of person I am, that I was going to be more comfortable not going flat, as some women to do, which is a perfectly fine choice, and that I also did not want to be bothering with prosthetic breasts the rest of my life. So
Can you
I
explain that to the audience, what you mean by prosthetic breasts?
Yeah, so people can use it's like a fake breast that is inserted into a bra or
Mm-hmm.
camis with a shelf, and you can get them in any size and shape. And I mean, the funniest thing was when I decided that I didn't want that, that instead I was going to go the implant route. I did the deep dive again on, which were the implants that we understood had the best safety, history. And I had very large breasts to start. I was in that 36 double D range. And when I went to have the implants, the conversation with the doctor about the implants, which was a plastic surgeon, she said to me immediately, we can bring you right back to where you were. And I burst out laughing. I said, does anybody ever want that? I mean, in a large breasted person. She said, oh, you'd be surprised. Most people want to go bigger. Well,
I have to tell you a story. I have to interrupt you. Just to illustrate this, I had a patient years ago who was very large bosomed, very large. She had a double mastectomy and she came in and said, I have a story to tell you. I had the booby prize, and her booby prize was getting rid of those bosoms that were just, her breasts had been so challenging for her. And I love the way she put it as a booby prize. Anyway, I had to tell you that.
I love that. No, and in fact, I said to the doctor, I'd like to, I'm a tall, thin person. I said, I'd like to have an A size breast. And she said, I can't do A, which sounded to me like a very strange, like male person saying that that's just too small for us kind of thing, or there's something weird. I said, well, what do you mean? She says, look, you're 5'8". If I give you an A, it's going to look like two little walnuts sitting at the top of your chest. What I'm going to do is I'm going to put in a B. And so what happens with many kinds of breast implants, they put in a size of an implant that then has to be filled with whatever they're filling it with. And that fill can go X number of times. So you can get the fill all the way up to, a B cup or a C cup or a D cup. And after 2 or 3 fills, I said, I think I'm there. Oh, she said, no, we think I said, I'm there. And this is true for doctors and non-doctors. Like, you have to advocate for yourself as a patient.
Yeah.
And I was very clear. And I have to say, for me, this is truly a silver lining of breast cancer. And at 54, which is how old I was when I went through treatment, I was very athletic. I was first wave of Title IX. I played 3 sports a year through high school. I played volleyball in college, but I never ran. I never did sports that involved running because the large breasts were a real big disincentive. So at 54, I took up running.
Wow.
And
it's great.
After my last chemotherapy that year, I said to my husband, in 6 months, I'd like to do my first triathlon. And I started doing triathlons because I could run. What a gift. And the added gift was that I didn't spend 30 years destroying my knees and hips. So I was in very good shape.
And also, you didn't have to shop for bras that didn't exist in most stores because large-breasted women often are really challenged by undergarments. So,
totally.
But I do want to.
I have not worn a bra since my procedure because my breasts are not going anywhere.
Right.
They're literally not going anywhere. It's so fun, and I can wear anything.
What kind of implants did you get?
I have silicone implants.
Okay.
And I had alloderm procedure where they basically, any of you listeners might be sewers, they basically whip stitch, if you will, an alloderm material in a kind of arced shape underneath the breast area to approximate the shape of a breast. And then that is your skin and your circulation kind of gets itself into that alloderm material. It becomes your own, and it acts as a permanent shelf in this area. And then the implant is put into that shelf. So I have them checked periodically, but it's been almost 11 years and I haven't had any issues. But
again, yeah, indeed. And I, particularly want to point out, as you just said, even as a clinician, someone who is well-informed, knew the verbiage that the doctors were using, had to speak up about, hey, no, I don't want those big bosoms. I want breasts this size, and stop. Yeah, thank you for sharing that.
I mean, I just would like to end by saying that this is not the choice or the correct path for everybody. It's such an individual thing. More and more women are choosing to go flat because they just don't want the hassle. And why implants are uncomfortable and it makes the double mastectomy more uncomfortable is that they insert expanders.
Mm-hmm.
Expanders help you to be able to accept this new thing coming into your body, and that those can be uncomfortable. So it's a longer healing if you're going for the implant. On the other hand, the research on the psychological state of not constantly being reminded. I mean, obviously you're reminded because, I don't have nipples. Now, some people who are having, let's say, prophylactic double mastectomy because they have the BRCA mutation, they can maintain their nipples. They sort of take them off to the side, remove the breast, put them back, and they get pretty good sensation for the most part. Other people that have had double mastectomies where the nipples are removed do report a sense of numbness in a bit of an arc around the middle of the chest area, maybe about the width of a quarter, and the loss of the nipple function, everything related to intimacy is a loss. That is a loss. So if you can, if you ask your surgeon, am I a candidate for nipple sparing mastectomy? That is a good question to ask.
Mm-hmm.
Breast cancer can recur to the nipple. So for most people, they're going through this thing, oh, just take it all. I don't want to be worried about it. And the other thing to remember for a lot of people who do not have the BRCA mutation, but mastectomy is the correct choice for them medically indicated, that if you get an implant, they can very often match it to your remaining breast, or some women will choose to at the same time either have a lift on the remaining breast or have a breast reduction on the remaining breast. So they've gotten quite good in terms of the cosmetic elements of this, understanding that people's self-esteem, hopefully it's not tied up singly in our breast, but it's certainly part of it.
Sure,
and
of course.
That's for people who are single, people who are older, people who are in relationships, people who are having intimacy, and people who are not. This is true across the board. So when I have a patient who's working with breast cancer diagnosis, this is a conversation, an honest conversation to have, and that to remind people that there is no right answer. There's the answer that's right for them at that point in time.
Do you share your history with your patients?
It depends on the patient. Some people come to me. I have been very public about my diagnosis. I wrote extensively on the Huffington Post. I was an invited author early on in the Huffington Post history, writing about topics in natural medicine. And when this happened, my first inclination, I said to my husband, I'm not telling anybody. We're just going to put our shoulders down, get through it. And he burst out laughing. He's like, that's just not your nature, which is so true. And literally the night I came home from the hospital, I wrote my first Huffington Post piece, probably with the best headline I ever wrote for anything, which was "Say Goodbye to the Girls." And I wrote about my experience, and then I kept writing about, and when you're going through chemo, here are things you can do to make your any cancer cells that remain more chemosensitive. And here's things you can do to help prevent side effects. And here's things you can do to mop up afterward. Likewise, with radiation, here are the things you can do before radiation treatment that help to protect your underlying organs. Here are things you can do to make any cancer cells that might be around more radiosensitive. And you can find that stuff is still all on the internet. And maybe in show notes, you can put a link to some of that, or I can send it to you. It's just that information has not changed, and we have added to it. We know more. There's been more research, but what's written and out there is still pertinent. And I think having some self-agency in general, when you're going through treatment for anything,
yep,
cancer, is so empowering.
Did you find?
I think being a physician, a naturopathic physician, informed every decision I made and everything I went through. Truly.
Did you find building relationships with allopaths, whether it was your surgeon or oncologist, was there some resistance? How was it to mingle both worlds?
It was totally fine. It was totally fine because I always came in with the stack of research showing, and this is why I'm going to be doing IV vitamin C during chemo. And this is why I'm going to be walking for an hour before radiation and getting myself to a nice little sweat before I get on that cold metal table. Here's the reason that I just always came in with the research supporting what I was going to be doing if I thought there was going to be any, reaction. And also, I'm a people person, and honestly, a number of the people that I worked with were patients of mine. So already knew who I was and the kind of work that I had done with them or with people that they had sent me prior. So I worked with a lot of providers because I had 2 different cancers that year and a lot of treatment, and I worked with many people. I wrote a book, which will be in the show notes, called "You Finished Treatment Now: What a Field Guide for Cancer Survivors." I had a wonderful publisher, and the book is done really well. But in that book, every one of my oncologists, except one, blurbed the book for me, meaning wrote praise for the book.
Right.
The one who declined basically was on maternity leave and totally stressed out. So, all right, we'll give her a pass. But, I think that I only say that because it reflects the mutual respect. I mean, these people saved my life.
Yeah.
They literally saved my life, and they've saved it over and again. So I owe the advances in medical oncology, the worlds of conventional medicine, I owe everything to.
So I want to I'm going to interrupt you for a moment because I think I don't want to lose track of two things. One, that not everyone out there is as informed as you and I might be, but I want to remind them that there are resources, everything from Amy's book to other ways of learning as best as one can what to do around cancer treatments before, after, etc. But the second thing I want to dive deeper into
Before we get into the second thing, can I just speak to that one real quick?
Sure.
If you're hearing this podcast, there's an organization which is called the Oncology Association of Naturopathic Physicians, OANP. And they maintain a terrific website with a lot of just information on it. But you can also find yourself a referral to a naturopathic doctor who has chosen to specialize in supporting people who are going through conventional medical oncology.
Great. Thank you. Thank you. Thank you. So can we dive into the second cancer that you were diagnosed with that you just mentioned?
Yes. So if you have the BRCA mutation, the idea is you would complete, and let's say you were diagnosed in my case with breast cancer, you would complete your breast cancer treatment. For me, that included the double mastectomy, 4 rounds of chemo, 28 radiation shots to my chest wall. And the idea would be to remove my ovaries. Now, because my cancer in my breast was estrogen receptor positive, I was going to be on estrogen suppression in the form of tamoxifen and then Arimidex. And I should say I was premenopausal at the time of diagnosis. I had no signs of perimenopause. I just was one of those women just going later into life without any signs of that. So initially I was put on tamoxifen like a premenopausal woman would. Of course, the chemotherapy put me into chemical menopause. After about a year, I was switched over to Arimidex for a number of reasons, which I'm happy to talk about if you want. But in any case, because we know that tamoxifen put people on a little bit of a risk for uterine cancer, instead of just removing my ovaries and my fallopian tubes, I was going to have a complete hysterectomy to help prevent ovarian cancer from occurring.
And just to remind the audience that that's because the BRCA genes increase the risk of breast cancer and the occurrence of ovarian cancer. So that's why Amy's speaking about having her ovaries removed. Yep.
Exactly. And so the doctor said to me, I'd completed my treatment for the breast cancer. Remember, I found the lump New Year's Day. I completed my treatment July the 1st. And they said, well, why don't we wait a year? Wait 6 months anyway. And then, we'll do the hysterectomy. And I said, you know what, this year has been so crappy. I did pretty well through treatment, to be honest, but, it's not the best time of one's life. I don't want to wait a year. Let's let my hematocrit get back to 35. That's your blood iron levels, which have taken a bit of a hit from the chemo. Let's let it get back to 35 is what I'm saying. And then let's just go for it because I don't want to bring this into the next calendar year. So about 3 weeks went by after my last radiation treatment, and I was scheduled for a complete hysterectomy. Unfortunately, they found cancer on both ovaries at the time of that hit. There was all my nodes were negative. I had what's called a clean abdominal wash. There seemed to be no spread. It was just local, but it was on both ovaries. So, the treatment for that 10 years prior would have been complete hysterectomy done. But times have changed and it became more take no prisoners, how about 12 more rounds of chemo? So that is how I finished out the rest of 2014. A lot of chemo.
Yeah, that was kind of a challenging year. Women with cancer in my office will sometimes describe a feeling of being betrayed by their body. That cancer, in spite of eating well, exercising, kind of living a clean lifestyle, that they feel their body betrayed them and that they have some anger. Did you experience that feeling at all?
I did not feel I did not feel that, although I've certainly heard that from many, many women and men
Yeah,
who have any diagnosis. It's not just cancer.
it's
People just
true.
feel like I did everything right, or people who didn't do everything right. People, I think it's a personality temperament thing. That was not the trope for me. I knew that my mother had died of breast cancer, in her late 40s. My sister had it numerous times. I knew there was a strong genetic component. I'm also very aware of the environmental impact of our slowly poisoned water supply, food supply, even though I eat organic and I have filtered water and all of that. And I don't know if anybody saw, we're recording this in June of 2024. There was an incredible article in the New York Times this week citing a study about the increased cancer rates that we're going to be seeing in the next generation, and the modeling that they're doing around this. It's truly frightening.
Yeah.
We all do things to impact our likelihood of developing cancer. There's certain things we know now, in terms of obviously smoking and, HPV vaccination, et cetera, et cetera. But for me, no, I didn't go there. And partly why I'm blessed with a very upbeat personality, so that I can't really take any claim for. But intellectually, as a naturopathic doctor, I also know of and have studied quite a bit the whole field of psychoneuroimmunology, the fact that your mind affects your nervous system and your nervous system affects your immune system. And so I knew right from the get-go that part of my job and how I could help this go as well as possible was to stay as positive as I possibly could.
Yeah.
And that was going to impact, we're all dependent on our immune system all the time. But in a cancer situation, I mean, we all have cancer cells floating around at any given moment, and our bodies have the capacity of finding them, recognizing them, getting rid of them.
Right.
In my particular case, I have a genetic inheritance that makes me not quite as good at that. But no, I didn't feel betrayed. I felt like, okay, we have a challenge here. I have a job to do. I need to get myself the right people around me. And I need to just do the things I know that give me joy and pleasure. And it's interesting because the whole time through, my providers would always say things like, Amy, you are doing fantastic. You're doing great. Whatever you're doing, keep doing it. And they never asked me what I was doing. And I was like, aren't you curious?
Right, exactly.
I was doing a lot.
Yeah.
I mean, I was doing a lot. But I also appreciate, like, they had their specialty and I was there with them because I didn't have that specialty and access to those tools. And so it was okay. And I didn't judge them. It just seemed funny to me. It's sort of like, wow, aren't you curious? Like, wouldn't you want to tell your other patients about this?
Well, there can be a certain amount of myopia in many clinicians. And, sometimes it's a result of timing. Sometimes it's a result of not interest, whatever. So I want to ask you a question, and you can say I don't want to talk about this if you don't want to. Sex, intimacy, that, many women who come into my practice who have had surgery that's impacted their reproductive organs, breasts, pelvis, etc. Talk about the challenge of intimacy in a variety of ways, everything from a lack of sensation to pain to feeling shame around the distortion or change in their body. Are you willing to go there a little bit with us?
Yeah, I mean, first of all, I would strike the word distortion from your vocabulary.
It's their word, not mine.
Not a good word for people to
embrace. Their word.
A lot of people have challenges in their world of intimacy predating anything related
That's
to
right.
illness.
That's right.
A lot of people. And this is true whether we're talking about people who are in a relationship that includes intimacy and people who are having intimacy with themselves through touch or massage or masturbation. So there's so many challenges here. One thing I think about the younger generations, there's much more openness about talking about things. And I think that the conventional medical world is really hearing this partly because younger people are, in general, I mean, this is a generalization, have a little less shame about it and have more language and more skill about talking about it. For me, I feel like my husband and I definitely took some months off, and then I felt ready to sort of, quote unquote, get back at it. And, I think not having circulating estrogen from a complete hysterectomy plus being estrogen suppressed on top of that, I would say that my libido was lower in general. And so instead of having more spontaneous interactions in that realm with my adorable husband, it had to be something that was more planned. Like, okay, we haven't really been intimate in a while. Let's set aside some time on Saturday, and then doing the things that we know make each other feel more in the mood to have that kind of intimacy. So being comfortable having a conversation like that. I think for a lot of women, lack of lubrication and pain and discomfort are very real, obviously. So learning about and finding the best lubrication for oneself, and then also remembering to be moisturizing in that area on a daily basis with gentle things like just coconut oil. There's a wonderful product made by a company, I don't have any affiliation with them, called Bezwecken, which is called a hydration pearl, which is a beeswax, olive oil, and coconut oil in small little pearls that stay in the fridge, and you can just insert those daily because you're trying to just keep the whole area moisturized as best we can. Of course, staying hydrated is important. And then I think for me, having a lot of intimacy that was not necessarily going to be ending in having sex remained important. And I've been blessed with a communicative, loving, patient husband. When you're in the middle of treatment, like it's definitely not the first thing on most people's list.
That's
trying
right.
to get through the day, keep yourself fit. It's okay. But it is important to get back to if one can. Now, some people are married or partnered and sex is not a big part of their relationship before, so we wouldn't really expect that to change too much afterward. I do want to put in a word for investing in having your gynecologist write a prescription for you. Many insurance companies will cover a good quality vibrator. That is, some women will need more stimulation. And I have had some patients where because things are not as they were, that they become actually better than they ever were because they get some tools to work with that oh, wow, I didn't even know that kind of thing. I could have that kind of, say, orgasm or that kind of feeling of pleasure. So a good vibrator is worth the money, and it's not the $4.99 from Target. This is
No,
cost
please.
you,
That's right.
$90. Yeah.
It's true. I mean, what we're talking about, on a technical level is bringing blood to the vulva and to the clitoris and to the vagina if you use it intravaginally. And, self-love, that taking care of one's body, whether it's before, in the middle, or after a diagnosis or in the absence of diagnosis, that's what we're talking about. And also some of this stuff happens as we age, and that the vagina changes as we go through the perimenopause and postmenopausal time frame too. So thank you for sharing that. And I want to stress that part of why I'm doing Gynocurious is about communication. And you just mentioned it vis-a-vis your partnership. And that, in fact, I think the greatest treatment for any sexual challenge for any person or persons is talking about it, saying it out loud, being able to bring words into the feelings and fears.
Yeah.
And this is hard for a lot of people for a lot of reasons. So start slowly, and if it means a date night, that's what I call those scheduled times. It's okay. That there's no right or wrong way of finding intimacy in your life, and you so beautifully described that. So thank you. So we're coming to a close, and you mentioned pleasure, and this is the way I like to end Gynocurious. What do you do when you're not working to give yourself pleasure in the grand schema of life?
I'm one of those people, I have like 100 answers. So.
Give us one. Give us one.
I'll give you the montage, which is basically, I love to move my body. I love to dance, rollerblade. I love to swim, go for a walk, or run, bike ride.
Great.
Also, somebody who loves to create. So I make paper, make books, make cards.
Great.
Sewing projects and things like that. But probably if I had to choose, if I was only allowed one thing, it would be to, choose a friend to go for a walk with and have a conversation.
That's right. Oh, it's true. It's true. I would agree with you. So I want to remind all our listeners that on the episode information, there'll be information about Amy Rothenberg's book and some tags that she'll share with me so that you learn more about naturopathy and perhaps breast cancer and some of the resources that she's mentioned this morning. Amy, thank you so much for your wisdom and you're sharing with us your journey. I appreciate it.
Okay, thank you so much for having me. It's a great show.
Thank you also to Jen Hammoud and Maddie Rosenberg, my co-producers, and to the Epicurean, this wonderful store in Rhinecliff, New York, that so kindly hosts Radio Free Rhinecliff. Until next week, our next episode, please stay well and listen to your instincts and intuitions. They are the greatest of teachers.